Hello, everyone. I'm sure there's going to be some people trickling in as we continue, but I'm going to get started with everything. My name is Miles Melamed, and I work in missions and outreach at Mending Kids. And I'll be taking over for Dr. Leah Jacobson tonight as the moderator. Unfortunately, she couldn't make it. So tonight will be part 5 of our 6-part audiology-focused ENT symposia in partnership with the graduate students of the Clinical Audiology Department at the University of Melbourne in Australia, and with our great partners at Bugando Medical Center in Mwanza, Tanzania. So just a reminder, if you haven't seen one of our symposia yet, please feel free to leave any and all questions in the chat as the presenters are going along. And then at the end, we'll try and address any questions that were left. And we will also open up the floor to discussion and live questions at the end of the presentation. So without further ado, on the behalf of Mending Kids, I'll turn it over to Jessalyn, Jacqueline, and Sophia. They will be presenting on tinnitus management tonight.
Thank you, Miles. Hi, everyone. Thank you so much for joining us today. I'm Jessalyn.
I'm Sophia.
And I'm Jacqueline.
And we're second-year audiology students from the University of Melbourne. And today we will be talking about tinnitus and how to manage this condition in our patients. So what is tinnitus? Tinnitus is the perception of sound with no external stimuli. This means that the patient can hear a sound that is not generated by the external environment. Tinnitus can be broadly categorized into 2 groups, subjective and objective. Subjective tinnitus refers to tinnitus with no physical origin. So this means that it's something that a person experiences and will describe. Objective tinnitus, on the other hand, is sound that can be objectively measured. It is sound that is being produced by a physical source inside our bodies, and that source can be either vascular or non-vascular in nature. Tinnitus that has a vascular origin usually occurs in synchrony with our pulse. It is usually described by patients as an audible, turbulent blood flow in the ears, and we refer to this as pulsatile tinnitus. The cause of this can be systemic or localized. The cochlea is a highly vascularized organ, and sometimes it can pick up on humming sounds. A common reason is the presence of a glomus tumor right near the eardrum. Tinnitus that is non-vascular in nature is not synchronous with our pulse. It can be due to middle ear myoclonus, where there is involuntary repeated contractions of the middle ear muscles, or a patulous eustachian tube, where there is uncontrolled opening of the eustachian tube. This results in internal sounds, such as chewing, becoming loud and audible to the patient. Subjective tinnitus makes up about 95% of tinnitus, and it also can be categorized into 2 groups, somatic and non-somatic. Somatic just means that the tinnitus is related to problems from the musculoskeletal system, such as head and neck disorders or injuries, TMJ dysfunction, and so forth. Features of somatic tinnitus include high-pitched constant ringing, and it normally involves the ear that is on the same side as the musculoskeletal issue. Hearing, vestibular, and speech are often normal, and neurological abnormalities would have already been ruled out. But the hallmark of somatic tinnitus is the presence of somatic modulation. Somatic modulation is when there is a change in the tinnitus following somatosensory, somatomotor, and or visual motor inputs. This includes tinnitus that alters with head and neck movements, tinnitus that changes with muscle contraction, tinnitus that is started by neck and muscle contractions, and tinnitus where the pitch or loudness is altered with muscle contractions. Non-somatic tinnitus is much more common than somatic tinnitus, and it makes up for the bulk of tinnitus that we do come across in our daily practice. The presentation of this tinnitus is highly variable. It can be a high-pitched ringing, or a low buzzing, clicking, or even a rushing sound like the ocean waves. The duration of this type of tinnitus is also highly variable. It can be brief and spontaneous, lasting seconds to minutes, or it can be acute and temporary, lasting minutes to hours. This one usually occurs after some sort of loud noise exposure. But when tinnitus is present for more than 6 months, it is classified as chronic tinnitus. Subjective non-somatic tinnitus is often associated with these conditions. Hearing loss is the most common one, followed by pathologies like otosclerosis, Meniere's disease, which was discussed last week, acoustic neuroma. Ototoxic medications can also cause acquired sensory neural hearing loss, leading to tinnitus. And common ototoxic medications include antibiotics like aminoglycosides and glycopeptides. Antimalarials like quinine and chemotherapeutic agents like cisplatin are also common ototoxic drugs. However, sometimes tinnitus can just be idiopathic with no apparent cause or associations. In terms of the prevalence of tinnitus in the population, about 80% of people would have experienced it at some point in their lives, with 10 to 15% having experienced constant tinnitus and 2% experiencing disabling tinnitus, which means it impacts their ability to concentrate, work, and it also affects their mental health, leading to anxiety, depression, etc. The prevalence of tinnitus increases with age, similar to hearing loss, and it also tends to be more common in men than women. This is reportedly because men are more likely to have jobs that expose them to loud noises, such as construction and working with heavy machinery. Prevalence of hearing loss increases with age, and for those with a hearing loss, the chance of having tinnitus increases with the severity of hearing loss, meaning the more severe the hearing loss, the more likely you are to experience tinnitus. Tinnitus is also quite prevalent in people suffering from hyperacusis. Hyperacusis is a disorder in loudness perception, where patients may appear overly sensitive to a range of sounds, finding many noises unbearable and painfully loud. 40% of people with tinnitus have hyperacusis, but a whopping 86% of those with hyperacusis will have tinnitus. Now, with tinnitus being so prevalent in our patient population, it is important to understand the effects that tinnitus can have on an individual. Studies have shown that chronic tinnitus is strongly linked with extreme distress, depression, anxiety, frequent mood swings, poor concentration, and often sleep problems. So in a nutshell, tinnitus can really affect a person's mental health and well-being when not managed properly. Sophia will now explain to us what we can do as clinicians to help our patients with tinnitus.
So what do we clinically test? How do we clinically test tinnitus to help with the management of tinnitus? So when a client comes into the audiology clinic at the University of Melbourne, there are a number of clinical tests that occur. First, we have a number of pre-screening questionnaires, including the Tinnitus Functional Index, the Depression, Anxiety, and Stress Scale, the Insomnia Severity Index, and a tentative history questionnaire. All these questionnaires are to really better allow the audiologist to understand how their tinnitus impacts the client's lives, and I will go into a bit more detail on the next slides. After the questionnaires, a complete hearing assessment will be done. However, additional extended high frequencies will be tested in the pure tone audiometry. So in normal pure tone audiometry, we normally only test up to 8 kilohertz. However, patients experiencing tinnitus may have normal hearing and have a hidden hearing loss in the higher frequencies. We will also then conduct the speech audiometry and tympanometry, which is part of the normal test battery in audiology. Other optional assessments can be the auditory brainstem response or the Loudness test, which is just testing speech and background noises. These are all to screen for any signs of hidden hearing losses that may be present. After this, we have the various tinnitus assessments that I will go through in the later slides, which include pitch making, minimum masking levels, residual inhibition, loudness discomfort levels, and somatic assessment, which is all to allow us to gain a deeper insight on the client's tinnitus pitch, loudness, and then allow and help provide further management down the track. So these pre-assessment questions, the main one is the Tinnitus Functional Index, which is a very helpful and useful questionnaire that divides tinnitus into 8 different subcategories of how intrusive their tinnitus is, the patient's sense of control of the tinnitus, the cognitive interference, sleep disturbance, any auditory difficulties, and how their tinnitus will interfere with relaxation, as well as how the tinnitus is impacting on their quality of life and how emotionally distressing it is. So there are some examples of the questions provided here of what is included in the Tinnitus Functional Index. So for example, the questions include, what percentage of your time awake were you consciously aware of your tinnitus? Or what percentage of your time awake were you annoyed by your tinnitus? Over the past week, how much did your tinnitus interfere with your ability to concentrate or your ability to hear clearly? And over the past week, how anxious or worried has your tinnitus made you feel? So these specific categories really just allow us as audiologists to better understand and help the patients manage their tinnitus. The other questionnaires shown here can also be used as well to just learn more about the impact that the tinnitus has had on the client's quality of life. So the depression, anxiety, and stress scale just measures the patient's emotional states of depression, anxiety, and stress. The insomnia severity index are just 7 questions that regarding the client's sleep pattern, the emotional feelings they have with their sleep problem, and how it will interfere with their daily functions. And lastly, the tentative history questionnaire is just an extensive case history regarding the origin of their tinnitus, when it started, the duration, what it sounds like, and if there are any correlating factors to it. I will now go through a bit in depth of the different tinnitus assessments that can be conducted. So the first one is the pitch matching test, which is to try and identify the pitch of their tinnitus. So I would say to the client along the lines of, I'll be playing you 2 tones, A and B. I would like you to tell me which of these is closest to the sound of your tinnitus. They will be different each time, a bit like an eye test, and I'll gradually try to hone in on the pitch of your tinnitus. So for example, the pitch of the patient's tinnitus is say around 2 kilohertz. We would have started A at 1 kilohertz, played that, then play B at 4 kilohertz. You play it one after the other and the client will choose A or B. So they will choose A as that is closer to 2 kilohertz. So then we would move A to 2 kilohertz and then move B lower to 3 kilohertz. And then we're able to hone in on the pitch of the patient's tinnitus. The next one is we will try to find what we call the minimum masking level. So the reason to do this is just to play a narrowband noise, which sounds like a whooshing noise into the air they have tinnitus in, and then we will gradually increase that noise centered around the tinnitus pitch. So we do this until it masks over the sound of the tinnitus, so covers the tinnitus sound, and that gives us a rough indication of the volume of their tinnitus. So we would say to the client, I'm going to present a whooshing noise into whichever ear they have tinnitus, or both, if they have tinnitus in both ears. I'll start very soft and gradually increase the volume. As soon as I reach a level where you can't hear the tinnitus anymore, touch the ear in which it has disappeared, both if it occurs on both sides simultaneously. So it is quite common for the masking of their tinnitus to be right at the threshold of their hearing level. So this masking can actually be very reassuring for some people because it means that the actual perceived volume of their tinnitus is not as high or loud as they perceived it. They might think the tinnitus sound is impacting them greatly and perceiving it as really loud and intrusive, but it might not actually physiologically and subjectively be that loud. Now, the residual inhibition is where we will continue to play that whooshing noise 10 dB above the minimum masking level we have found previously. And we play that for around 30 seconds to a minute. So you would say to the client something like, now I'm going to be playing that whooshing sound for a short period. When I switch it off, I would like you to sit in silence for a few minutes. Listen for your tinnitus and see if there are any changes. Is it softer, louder? Does it disappear altogether, and for how long? Does it change in pitch or tone? So after the 30 seconds to a minute, we will turn it off and we will sit in silence to see if the patient has experienced some residual inhibition of the tinnitus. So total residual inhibition is when the tinnitus may disappear completely, which is very rare, or there may be some partial residual inhibition where the loudness of the tinnitus has been reduced. This is a very good test to see whether using a masker, which we'll talk about later, as part of our management strategy would work. Because if their tinnitus got louder after this test, then a masker would be detrimental to them and should not be part of their management plan. The other test we do in the clinic is the loudness discomfort level test to find out the loudest level they can tolerate and screen for hyperacusis. So hyperacusis is a disorder in loudness perception, as Jesslyn mentioned previously. So where patients will be overly sensitive to a range of sounds and often finding a lot of noises unbearable and even painfully loud. So you would say to the patient, I will play you a repetitive sound and gradually and rhythmically increase the volume. I would like you to tell me as soon as it reaches an uncomfortable level. Let me know as soon as you don't want to hear the next level. So you would test at a low and a high pitch sound starting at 55 dBHL, and then you would rhythmically increase the volume until the patient tells you to stop. So for normal levels, that would be if we found the loudness discomfort level to be more than 90 dBHL, and the results would be abnormal if the level was below 70 dBHL. Lastly, the somatic modulation testing is to determine if there is any somatic correlation to the tinnitus, either in origin or exacerbates tinnitus with specific movements, as Jesslyn previously talked about. So you would tell the patient, I'm going to ask you to do a series of head, neck, and jaw movements. Listen to your tinnitus with each movement and let me know if you hear any changes in your tinnitus, such as it becoming louder or softer, if there's a pitch change, etc. So then, as you can see here in the table, you would then list the result in the table, whether there was a positive or negative change if their tinnitus had changed from the movements. So what can we do to help manage tinnitus? The best practice for tinnitus management is really a multidisciplinary, multifaceted approach. Masking, as discussed before, is often used either through white noise or a nature sound, as long as it is a steady state sound that the brain can habituate to. This is so that it can trick the brain into habituating long-term to the sound of their tinnitus. Masking is therefore used a lot in the tinnitus clinic, and there are a few different apps as well we can recommend to our patients, which can be downloaded through the App Store. Hearing aids are often very helpful and used only if the person has a hearing loss as well. If there is a hearing loss, their sensory input along the hearing system has been reduced. If we can increase the sensory input by matching the hearing levels through the hearing aids, we can essentially mask the tinnitus. But as a clinician, it is really important to help the patient understand their tinnitus and overcome the fear of it, thus help ease their stress. We can provide them with ways in which they can manage stress, such as meditation. Jacqueline will go into depth about this later on. But the end goal of this tinnitus management plan is really to help clients gain control. Their tinnitus is not a disease, it's a symptom. And although we cannot cure tinnitus, it is really important to highlight to people that there are ways to manage it, and management strategies can go a long way to reducing their stress, anxiety, and fatigue. Even just acknowledging to your patient that it is okay they have tinnitus. For long-term management of the tinnitus, it has seemed to be very effective to treat people with tinnitus through the different multidisciplinary referral pathways, as shown here, through the physio, either psychologists or sleep clinic, or even a meditation center or dentist. And Jacqueline will go through a bit more in depth later on. So as I say that, I will now pass it on to Jacqueline to go through what other strategies patients can do outside of the clinic.
Alrighty, so what can be done outside of the clinic? One of the main things we would like to emphasize is the ability to ignore tinnitus as best as possible. You may be able to retrain your brain and ignore it by doing various things such as sound enrichment and counselling to alleviate any negative reactions to tinnitus, as Sophia has mentioned previously. There are many things we do in our daily lives that we don't notice, such as the feeling of clothes touching our skin or the sound of our own breathing. Tuning out the tinnitus is also something that can be trained to do. Of course, this is easier said than done. The brain starts to associate emotions such as anxiety, stress, anger, or even depression with the sound of tinnitus. Many counselors can go through the process of training your brain to disassociate the negative emotions with tinnitus. Counselling is something that can be offered to patients to assist with the habituation of tinnitus that may be causing emotional distress, loss of concentration, or disruption to sleep and work. These counsellors can provide information to allow the patient to understand what tinnitus is and how they can correct false beliefs to alleviate the stress that may be associated with tinnitus. These counsellors can also provide information about realistic goals of different treatments available and assist their patients as best they can. Additionally, several things can be done, such as avoiding extreme silence. When we block out every single sound, we tend to feel as though we hear the tinnitus louder, due to there being silence that isn't natural in comparison to hearing background noise daily. Avoiding wearing earplugs that shut out all the external noise is something that can prevent you from thinking about the tinnitus too much, allowing you to focus on the external noise to drown out some of the tinnitus. Furthermore, keeping busy and focusing on stimulating activities will enable you to stop thinking about the tinnitus and get your mind off the internal sound that may be causing you to feel those negative emotions mentioned previously. And also playing the radio on a soft volume or listening to relaxing music is also something that can assist you with drowning out the tinnitus greatly. On the note of playing relaxing music, another thing that reduces tinnitus largely is the amount of stress someone can be going through. Doing activities such as meditation, yoga, or anything that may relieve your stress would help you avoid these stressful situations and thus reduce the tinnitus present. Additionally, hearing aids can also be of help to tinnitus if there is a hearing loss associated with it. By stimulating the auditory system and increasing the clarity of the sounds that were once missed, it provides additional sound to the brain, allowing it to pay less attention to the tinnitus. By having hearing aids, it essentially allows people to hear around the tinnitus and focus less on it. There may be other reasons as to why the tinnitus is present. There is something called the temporomandibular joint, or the TMJ, which is the joint that connects the jaw to the skull. When inflamed, it can spread to the eardrum, which may result in tinnitus. Going to see your general practitioner to determine whether this is the cause of your tinnitus will allow for multidisciplinary referral pathways to occur, such as a referral to the dentist. Dentists can undergo several TMJ therapies, which allow for the alleviation of the TMJ inflammation, as well as the tinnitus in some cases. There are other referral pathways to physiotherapists, psychologists, sleep clinics, and meditation centers that can be offered if a general practitioner deems it is of necessary help. In some cases, tinnitus can be elicited by the somatosensory system of the cervical spine, or again, the temporomandibular area, and the somatosensory system can alter the intensity of tinnitus by forceful muscle contractions of the neck and jaw muscles. This is called somatic tinnitus, as mentioned previously, and it has been found that physical therapy can be part of a treatment plan for patients who are found to have muscle tension in the tensor tympani muscle. That is just some of the things that can be done outside of the clinical setting for some tinnitus relief. It doesn't always work for everyone, and everyone can have different types of tinnitus and symptoms, but hopefully some of these recommendations and advice works for the majority of the people you see. In relation to the advancement of tinnitus management, there are ongoing studies further investigating the opportunities for improvement in the treatment of tinnitus. One of the largest studies currently happening is a longitudinal study that involves a non-invasive device that applies a technique called Bimodal Neuromodulation, which combines sounds with zaps to the tongue, which was found to be an effective way to provide relief to tinnitus patients. This study was accidentally conducted when the researcher, Dr. Hubert Lim, was doing a deep brain stimulation on a patient who actually had tinnitus, and an electrode went off course, touching other areas of the brain, which caused the patient to not hear any of their tinnitus anymore. Bimodal neuromodulation is a technique that combines sound stimulation with electrical stimulation of non-auditory peripheral nerves, which can drive neuroplasticity and can be relevant for tinnitus treatment and improve symptoms of tinnitus. In this research, they present pure tones to the ears that were synchronized with electrical pulses presented to the top surface of the tongue, in hopes of pairing these zaps with sounds would rewire brain circuits associated with tinnitus and promote the activation of brain circuits in response to different sounds to drown out the tinnitus. In short, they suppress the tinnitus neurons by stimulating and elevating other neurons around them instead. This study consisted of participants undergoing 12 weeks of treatment with a 12-month post-treatment phase, with the reports of reduced symptoms of tinnitus at the end of the treatment. Due to these positive results, it has motivated further clinical trials towards the establishment of bimodal neuromodulation as a clinically recommended device treatment for tinnitus. I'm sure we're getting close to some more treatments to tinnitus, but in the meantime, there are other things that can be done to relieve the tinnitus symptoms. With the advancement of technology, there are many apps that can help with tinnitus in an individual setting. There are many apps that can mask the sound of tinnitus, such as T-Mask or Tinnitus Play, which can be a powerful coping tool for tinnitus sufferers. These apps use various types of background noise to cover most of the sound of the tinnitus, and for some people, it can provide immediate temporary relief to help tinnitus sufferers focus less on the sound. There are other apps such as Belltone Tinnitus Calmer, Resound Tinnitus Relief, and Tinnitus Treatment, for example, which may allow the habituation of tinnitus itself. These apps include several things such as meditation tracks, sounds that assist with sleep to mask out the tinnitus, and educational video content to help understand and habituate the tinnitus. These apps are constantly appearing with the rapid advancements we are constantly having, so keep an eye out for some apps as well that may pop up available on your phone. In terms of further advances in tinnitus, keep an eye out for many to pop up in the upcoming future. There is so much room for improvement with the treatment of tinnitus, and I know it'll make a great impact on our clients who suffer from tinnitus every day. So we now have a case study that we'd like to quickly go through. So we've got a client here. Her name is Joanne, and she is 50 years old. She has been exposed to loud noises as she's played in a band for many years. She experiences a constant high-pitched tinnitus, which sounds like cicadas. It is difficult for her to go to sleep because of the tinnitus, and she has noticed some stress and fatigue. She's got some hearing difficulties as she watches the TV on a loud volume and asks for repeat from her partner at home. So we've got some additional information such as no family history of hearing loss, no recent visit to the ENT, and her general health is good. In terms of this case, we would go through the questionnaire that has been filled out for us and ask more questions about the tinnitus, such as whether she noticed it changing in pitch or loudness when she does certain movements with her head and jaw. We would then go through all the tests that Sophia has mentioned previously to get an idea of what might be helpful in terms of relieving the tinnitus sounds. For example, if we find her minimum masking level and she finds that it's drowning out her tinnitus, we may be able to recommend the masking apps for her when she goes to sleep. Although we said that tinnitus cannot be cured, there are things we can do to manage it through these appointments. And through this, we can try and figure out what is best suited for our client. So some take-home messages that we have is 1, tinnitus is not a disease. It is a symptom that cannot be cured. 2, the best thing to do is to try and ignore it as best you can to avoid it taking over your quality of life. 3, to seek out help from health professionals when the symptom becomes too much. And 4, to try different techniques to get rid of your tinnitus, as each person's technique may be different. And lastly, and most importantly, as a clinician, be someone your client can express their concerns to. Listen and acknowledge that they may be going through a difficult time and they've come to you for help.
Great. Now we just have a quiz. It's just 4 questions and they're multi-choice. So for the first one, just if you were to pop your answers into the chat box. So the first question is, what are the 2 groups that tinnitus can be categorized into? A, subjective and objective. B, non-somatic and somatic. C, modulation versus non-modulation. So just, pop your...
We've got an A so far.
Yeah, we've got an A. That's great. Okay.
Anyone else?
Is there anyone else?
No, we'll take Jason's
Good.
answer.
Perfect. Great. Good job. Perfect. Okay. The second question is, what is the cause of tinnitus that is experienced as a humming sound? A, somatic, B, non-somatic, and C, objective. Okay.
Can you take Jason's?
Yeah. Give. That's
If
okay.
there's no answers, it's okay to just.
Yeah, that's all good. Okay, so B is the answer, non-somatic. Third one is, who can you refer the patient to if their temporomandibular
joint
is inflamed? Doctor, A, B, dentist, C, psychologist, D, physio.
There we go, we've got a B.
Perfect.
Perfect.
Great. And then number 4, what is one way in which we can help our patients manage their tinnitus? A, stress relief, B, masking program, C, psychologist, D, or above.
Great, Jason's popped in.
Jason's
D.
got it all.
Yeah.
Perfect.
So that is it for our presentation today. We hope you all have learned a great deal about tinnitus and can pass it on to your clients, friends, and family to spread the aware of tinnitus. Thank you. Are there any questions before we wrap up?
Yeah, so at this time, Chawi, if you can allow everyone to unmute themselves, we'll open the floor up to any questions. And you can either unmute yourself and ask, or if you want to put it in the chat, that is also okay. And yeah, thank you to our presenters. That was a great presentation. Lots of interesting information.
I think we're all good. Any questions?
Any questions?
Thanks, guys. I thought that was a really great presentation. I think one of the things that might be kind of important to mention is how tinnitus, if it is unilateral, that's a red flag as well, that we want to be kind of careful of, because having unilateral tinnitus, especially if there's other symptoms that are unilateral, it could indicate something perhaps wrong with the auditory pathway, retrocochlear pathology. So just something to be aware of and mindful of, that if someone's just got tinnitus on one side, there can be reasons for that. But yeah, I just had wondering of any of our audience here. I think tinnitus is one of these things that perhaps affects everyone in their life at some points. You know, either you've been involved in been part of a really noisy concert, or you know, a bit of noisy work, or you've forgotten to put the ear protection on. It affects a lot of people, and I'm wondering, you know, whether this is something that's common, that's coming up. We've got a lot of ENTs and doctors on here. So is this something that's really common that you see in your practice? And hopefully some of what has gone on today has really helped to empower you to know kind of that there are different options around. So I'm just wondering, just in the chat, or even if people want to come online and talk about tinnitus, how that might be, whether it is a common thing that you're seeing in your practices.
Thank you very much, guys, for the talk. My name is Dr. Macharia. I'm in Nairobi. Just one thing I wanted to ask. Whenever I see tinnitus patients, actually, we do see a lot of tinnitus patients where I work in two settings, both a private and a public setting. So in the public setting, I don't see too much tinnitus. That's our public hospitals. But in the private setting, a whole bunch of our patients come in with tinnitus. And you're right, it is definitely linked with stress and anxiety, especially during this COVID period. We saw a whole bunch increase in tinnitus as well as globus. So my question is, patients come with different descriptions of their tinnitus. Of course, there's the classic one, like the pulsatile one that we feel that could be either arterial or venous, you know, but patients come with different descriptions. They come with a high-pitched tinnitus, the tee. Others come, they say that it feels like a engine rumbling or like crickets. I don't know what cicadas are. Others come with, they say it's like a whooshing sound. Oh, it's something similar. Okay.
Yeah, it's sort of really high pitch. We have them
Yeah, crickets.
here in Australia. Yeah.
Yeah. Some of them say it's like leaves rumbling or somebody stepping on leaves. Others say it's like or like the wind blowing or somebody humming. So my question is, because I feel like sometimes our tinnitus management doesn't work because we don't have the right diagnosis. Does a description of the tinnitus, or is there a way that we can, does a description of the tinnitus, the physical description of it, or the audiological description of it, sort of point towards a source? Because even some patients say it feels like a tap, you know, like something is tapping inside their ears. So I do wonder whether you guys see any of that stuff. Thanks.
Great question. So I'll pass that over to our speakers if anyone wants to have a crack at answering that one.
Yeah, so normally when patients come in and they describe the sound of their tinnitus, we do find that there is usually a close link between hearing loss and tinnitus. And most of the time, the pitch of the tinnitus that they hear, if they have a hearing loss, it usually coincides with the area where they have the most hearing loss. So normally if they haven't had an audiogram or a hearing test done, that might be a good idea. So if someone comes in and they report having tinnitus, it is part of our normal assessments to then refer them to get a hearing test done and to see whether like the pitch of their tinnitus matches any areas of hearing loss. But of course, there are some cases where they might report, say, like a low rumbling sound in their tinnitus, and their low frequencies might be good. In that case, that would just affect our management. So in terms of management, like Sophia said, what we would do is something called pitch matching as well, where we will sort of try and identify the pitch of their tinnitus and use that for the masking noise. So what we do is we set the masking noise to be the same pitch as their tinnitus, and then we find out what their minimum masking level is I guess, say the volume at which their tinnitus is, and we try and match that up so we know at what pitch and at what level to play the masking that to help manage their tinnitus symptoms. Yeah. Does that make sense? Do you have any questions after that?
Thanks for that. Thanks for that.
Anybody else have anything else to add on that one?
I think if like you've got the tinnitus that isn't the typical high pitched ringing, or some people have like musical tinnitus as well, you could always do some of the other things to relieve it, like drowning out the sound with other sounds, like keeping busy, trying not to focus on it too much. Having other sounds stimulating allows you to focus less on the tinnitus. And I guess you can't always match it with like the pitch if the pitch is there, but you can always try those other managements to see if you can relieve it a little bit, I guess.
Yeah, I think the really crucial from a clinical point of view, I guess, Ian, is the history. I think based on the tinnitus alone, the signal, it gives you a bit of an indication of where it might, the origin of it. But that's really the importance that that we place on getting it properly assessed. And if you have got audiology at your clinic, getting a really solid hearing test done that includes tympanometry, because sometimes even a bit of eustachian tube dysfunction can cause a bit of low frequency humming as well. So, and sometimes it's really simple nasal sprays that can kind of help to improve it, as opposed to, someone that's got Meniere's disease, for example. So taking a really solid history, I think, is really important, and also running through some of the somatic assessments that the guys talked about today, and then clearly referring off if need be as well to the appropriate person if we felt that's not necessary. But I think, I guess we'd probably argue that audiology is perhaps at the top of your list about who you might refer to in terms of, the overall management of patients with tinnitus. Hopefully that's helpful.
Thank you, Ian, for the question. Is there any others?
Yes, hello, this is Heather. Can you hear me?
Yes. Hi, Heather.
Hello. Can children be affected with tinnitus but don't know how to report it?
Yes, so it is possible for children to experience tinnitus, though usually, as we mentioned, tinnitus, there has been some associations with hearing loss. So we don't tend to find as high a proportion of children getting tinnitus as compared to adults. So normally when we do our history with children, we normally don't ask them specifically as well if they experience any tinnitus, because sometimes children might just hang on to that. And, some children might say that they have it even if they don't. But I think if children come in and then they self-report it without being prompted, it is something that you can investigate. And I guess one of the first things that you would do is obviously do a hearing check to see, how their hearing levels are. And you can do some of those like somatic assessments and the other assessments that we talked about in children as well, if you want to do any further investigations with their tinnitus.
Yeah, I would agree with that. Thanks, Jessalyn. And I think you'd probably really be a little bit more careful with children and getting them properly assessed, getting their TMJ assessed properly, seeing the dentist, and making sure there's nothing else that's causing that. In children, it's less common, we think. We're never 100% sure, but we think it's far less common in children than it is in adults. But it certainly is something that occurs with children.
Do we have any more questions? Okay, so it looks like we are good. I want to thank our presenters and also thank our audience. And moving forward, please feel free to reach out and send an email to either Dr. Leah Jacobson or anyone at Mending Kids via email if you have any questions, or if you have a specific topic that you would like us to cover in a future symposia, please do not hesitate to reach out. We like all of that feedback. The next presentation, which will be part 6 and the final part of our audiology focused ENT symposia series, will be on May 20th, which gives us a little break. It's about 2 weeks away. And we will send a reminder email when that approaches. And that's it for now. Thank you, everyone.
Thank you.
Everyone.
Guys.
Thanks, guys.
Bye.